I'm really grateful to be here today because early life trauma is so important in chronic pain, and it's something that we don't see, right? So you're going to have people coming into the clinic, and they'll have this whole tapestry of experiences. But unless we ask about that, and unless we're cognizant of that, we're not going to know that they've had these experiences. So the talk today is going to be structured in 3 different sets. So we're going to talk about what is trauma, and then we'll talk about what kind of outcomes are associated with trauma, and then finally, what we do clinically. So first, a simple question: what is trauma? What are we talking about? Well, in general, trauma can be a stressful experience, something that causes a great deal of hopelessness, fear, feelings of horror and injury or the potential for injury. And oftentimes these experiences make us think of something acute, an acute trauma, something like a motor vehicle accident or the stereotypical thought of a stranger perpetrated rape. But oftentimes these events vary in quality, right? So these can vary in terms of degree of horror, in terms of the hopelessness that individuals experience, how often they occur, if they're repeated, how long individuals have to encounter these experiences, and also if they experience a whole spectrum of co-occurring events. In 1992, Judith Herman published a paper that addressed this heterogeneity. She was concerned about the complexity of PTSD. And she talked about this different type of trauma that individuals are experiencing, which she called complex trauma. And complex trauma are events that are prolonged, they're repeated, they're often of an interpersonal nature, and these individuals can't leave. They can't escape this trauma. The prototypical type of complex trauma is childhood abuse or intimate partner violence, domestic violence. Interpersonal trauma is unique. So interpersonal trauma is something that's perpetrated by another individual. These experiences are often caused by the motivation of the perpetrator being an intention to cause harm, but it can also be that they're attempting to pursue their own goals without any concern for the type of harm that is inflicted on the individual. And this encompasses violence victimization, so abuse, rape, assault. And the notion of complex trauma in and of itself takes this into consideration, this idea of interpersonal trauma. Betrayal trauma theory also highlights this aspect of trauma, and it suggests that the seriousness of a traumatic event and the impact that it has on an individual is a function of both the fear that it elicits and also the sense of betrayal. And the sense of betrayal is any act in which a trusted individual, someone who is needed for survival, violates the person in some way. And this causes a violation of trust. And this happens on a spectrum. So betrayal from someone who is closer to that person, like a mother. If a mother hurts a child, that's going to elicit a stronger sense of betrayal than an event that occurs at the hands of somebody who's not as close to the individual, so someone who's like a babysitter. Betrayal trauma is associated with a stronger impact on outcomes. So we found stronger impact on psychological and physical functioning associated with these types of traumas. And the graph on this screen shows the probability of exposure to different types of trauma, those that are rated as most upsetting in that individual's life, because oftentimes people experience multiple traumas. So the most upsetting in that individual's life and the probability of PTSD diagnosis. And you'll see that these events that occur in an interpersonal context, rape, assault, molestation, abuse, these are more strongly associated with PTSD. So what does interpersonal trauma look like? And that's a really complicated question. Childhood maltreatment encompasses acts of commission and acts of omission. So commission includes emotional, physical, and sexual abuse. And omission is neglect or failure to provide adequate care. But what's important to keep in mind is that interpersonal trauma can be experienced throughout an individual's life. It's not just within childhood. And people experience multiple types of trauma, so what's called polyvictimization. And as individuals enter into childhood, right, so into the school system, peer victimization is common. As individuals enter into adolescence, you have the potential for new romantic relationships, which pose a risk for teen dating violence and sexual assault from peers. And then also close relationships in adulthood. Marriage, right? Individuals are at risk for experiencing domestic violence. Again, physical, sexual, psychological abuse. So interpersonal trauma really intersects type of abuse. It intersects with developmental timing, because it can happen across the lifespan, and also relationships. And unfortunately, interpersonal trauma is far too common. So approximately 1 out of 4 children 17 years of age and younger report that they've experienced some type of maltreatment in their life. And these events do not happen in isolation. So I think now most people are aware of the Adverse Childhood Experiences study, which was a very important study that looked at a multitude of different adverse experiences, not just violence victimization, but these adverse experiences among individuals in primary care. And these events, and I'm going to focus on this interpersonal trauma, these events frequently co-occur. So individuals who experienced psychological abuse, about half also reported physical abuse, and about half reported sexual abuse. For those who reported physical abuse, about half also reported psychological abuse, half reported sexual abuse. And for those who reported sexual abuse, about a quarter reported physical abuse, and about a quarter reported emotional abuse. So again, this polyvictimization. And when we look at any one type of adverse childhood experience, up to 93% of individuals also experienced one additional adverse childhood experience, and up to 74% reported 2. So people are experiencing multiple types of adverse childhood experiences. And individuals who are abused as children very often experience abuse as adults. Macaulay's study looked at female patients at 4 community-based internal medicine practices, and half of childhood abuse victims also reported abuse in adulthood. So we're going to be moving into a discussion of the impact of these events on individuals. But before we do, I want to emphasize that there's numerous things that can modify the impact of these experiences for individuals. And this is just a little piece of that, right? So I'm going to give a few examples, but again, there's multiple things. But Thompson and colleagues found that physical abuse in childhood was associated with mental health conditions in adulthood for women. I'm sorry. Oh, I'm sorry. So good. Were associated with mental health conditions in adulthood for women, but not for men, and with perceived health for women in adulthood, but not for men. Following up on these gender differences, studies have also found that sexual violence can uniquely impact men. So men also experience rape. And this doesn't just result in a violation of the physical body for men, which it does for women, but also just a destruction of traditional gender roles, right? So in cultural ideals and gender stereotypes. And men very seldom seek help. And frankly, it's very often lacking for men. So this can uniquely impact men. Also, developmental timing of abuse is important. And race and immigration status, which I don't think I have up there, race and immigration status can also impact the effect of these experiences, because it may lead to a desire to keep that experience within the community, to not reach out to outsiders, right, to deal with it within that community. And I don't think anything can capture the heterogeneity of these experiences as well as the individual's words. So I think in research we very often just look at the numbers and we forget that this is a very human experience. But looking at what they say is important. And so on the screen I have the words of victims of violence, a man who is recounting abuse from his father, 2 young girls who are recounting abuse during adolescence. One was sexual assault, and the other was a physical assault. And then finally, a victim of domestic violence. So now I think it's important to keep in mind the things that I have mentioned, right? So you can see in childhood and in a domestic violence situation, the individual can't escape, right? So they're constantly waiting for that next experience. They are stuck. And that's going to impact individuals differently than someone who experiences a physical assault, and that is a terrible experience, causes a great deal of fear. They feel stuck for that moment, but they can go home, and they can get away from it. So I think keeping that in mind, and we can look at the research, we can look at the numbers, but these are very, very different experiences. Okay, so let's move on to a talk of the outcomes associated with interpersonal trauma. And I like the words of Bessel van der Kolk, who is a well-known trauma researcher. And he emphasizes that what's most important is that when individuals experience trauma, it changes the brain. This is changing the ways that individuals see the world, the way that they process this information, and that behavioral set of ways in which they can respond to stimuli in their environment. So I first want to take a deep dive into what's happening inside of this person, right? Let's talk about the brain, and this is important. So teacher and colleagues suggest that brain changes that we see among individuals who have experienced interpersonal trauma are adaptive. Trauma alters the development of the brain in a way that is going to help the individual survive their environment. It's going to help survival. It's going to aid in reproduction in a world that's dangerous. Neuroimaging studies suggest that the type of abuse matters for the structural and functional differences that we see. And what's important is that these changes may work to alter, or specifically attenuate, the impact of repeated abuse and the processing of repeated abuse in order to lower the conscious perception of it to help with distress. It's also going to impact the way that individuals perceive reminders of the event. But it's going to leave intact these subcortical pathways that provide this non-conscious route to these behavioral and emotional responses to threat. So there's this change in sensitivity to threat, in the perception of threat. There's also sensitive periods during which interpersonal trauma, during childhood and adolescence, have unique effects on observed changes. And again, this interacts with the type of abuse that people experience. So the graph on the screen is just one portion of what teacher presents, but I think what's important to recognize with this graph is that it's showing heightened periods of vulnerability with age on the x-axis. So as you can see, across different brain regions, there's different age periods that pose heightened risk for differences in gray matter volume. And there's also sex differences that have been observed. And I think it's important also to keep in mind that interpersonal trauma is viewed as threats to survival, yes, but also threats to sense of self and threats to body integrity. All of these things are perceived as threats in the environment. I want to give, skipped ahead. I want to give really quickly a few examples of some of the changes that have been seen. Let's see. Oh my goodness, I'm so sorry. Skipping ahead. So what we found is that among, I'm so sorry, I can't find the mouse, is that what we found is that among individuals who have experienced abuse, there's differences in the sensory perception in the brain. And this is type dependent. So individuals who have experienced emotional abuse, there's differences in sense of self, these areas that are involved in sense of self. For individuals who have experienced sexual abuse, there's changes in the region that's associated with sensing the genital area and also with face perception. Individuals who have experienced parental verbal abuse, there's changes in the auditory cortex. Okay, so this is type dependent. They've also found that there's differences in amygdala response in terms of threat perception and heightened reactivity to threatening faces, especially like hostile faces or ambiguous faces, things that can appear threatening to individuals. There's also changes to the default mode network, although those studies are often among individuals who have psychiatric disorders. So we don't know much about these changes, and the talk by Rick earlier was wonderful, but there's so much that we don't know, right? So there's a whole area of research there that needs to be done. Now, if we step outside of the body now, we look at interpersonal trauma and what we can see. And there's dysfunction in multiple domains, including affective, social, cognitive, and physical health domains. So individuals who have experienced abuse, including childhood abuse, it's associated with lower emotion regulation skills, higher rates of depression and anxiety and post-traumatic stress symptoms. Individuals who have experienced interpersonal trauma also experience differences in social information processing and attachment. They perceive their relationships more negatively. There's also changes in cognitive functioning, including in working memory function. And then finally, there's differences in this physical domain. So there's heightened sensory sensitivity, more pain. There's sleep difficulties, especially among individuals who have experienced adult intimate partner violence, and also painful and somatic symptoms and widespread pain. Now, what about the relationship between interpersonal trauma and pain, which is why we're here? So this has been a topic of increased interest recently. So on the screen here, this is a PubMed search for articles related to violence, victimization, and chronic pain. And you can see that the number of articles per year has grown. So this is definitely an area of interest. And indeed, interpersonal trauma is associated with chronic pain. Retrospective self-reported abuse is associated with self-reported pain experiences. Individuals with a pain-related diagnosis are more likely to report a history of abuse compared to healthy controls. In our work at the Back and Pain Center, we find that 15% of patients report physical or sexual violence. It's also associated with FM diagnosis, so upwards of 60% of individuals within chronic pelvic pain conditions and fibromyalgia report a history of abuse. And to flip the script, West looked at individuals, women, who recently left a domestic partner who was violent. And she asked them about their experiences of pain. And only 5.5% of the women said that they had no pain. And on the flip side, a third of the women experienced debilitating pain. What's interesting is that if we revisit these domains of functioning implicated as outcomes of interpersonal trauma, and we look at these domains of centralized pain, which have been highlighted by researchers at the Chronic Pain and Fatigue Research Center, which includes space, which is the sleep, pain, affect, cognition, and energy component, and then this generalized sensory sensitivity, we see a great deal of overlap. So they're experiencing deficits within these same domains as what we look at with centralized pain. And there's a few things that aren't included, however. deficits in social functioning, social dysfunction, and attachment difficulties, changes in social information processing, and also post-traumatic stress symptoms. So what can we do? And again, hearkening back to the words of Bessel van der Kolk, these words by Felitti I think are really important. These experiences stay with an individual. They're part of the fabric of that person. Time does not heal the wounds that occurred in those earliest years. Time conceals them. They're not lost, they're embodied. And this is important to keep in mind when we see patients in the clinic. The first important note is that victims of interpersonal trauma are going to be more difficult to treat, right? So these individuals show higher healthcare utilization, more somatic symptoms, higher pain severity and interference, higher disability, higher psychological distress, including anxiety, depression, and PTSD, more negative pain-related cognitions, like catastrophizing, and also lower perceptions of social support. And if we think about the impact on attachment, that's going to impact how individuals see their physician and how they respond clinically to those who are attempting to treat them and help them. Victims of interpersonal trauma may also respond differently to pain-related treatments. So we at the Back and Pain Center explored differences in self-reported side effects to pain medication. And again, these were self-reported. We simply asked new patients to indicate whether they had experienced any side effects to pain medications when they were first coming into the clinic. And we looked at groups by trauma history, which includes no abuse, childhood abuse only, and again, this is sexual and physical abuse, adult abuse only, and both childhood and adulthood abuse, what we call cumulative abuse, these events that occur across the lifespan. And as you can see, this graph on the screen shows the number of individuals within each group, or the proportion of individuals within each group who reported this side effect. And the asterisks show these omnibus differences. Individuals who experienced no abuse typically showed the lowest proportion of reporting these side effects. And on the other hand, individuals who have experienced cumulative abuse had the highest proportion. And what's not included on this screen is that we looked at mediation, and this was partially mediated by centralized pain. Interpersonal trauma may also drive the need for treatment. We also explored the co-use of benzodiazepines and opioids among individuals at the Back and Pain Center. And again, looking at the same groups of trauma, no abuse, childhood abuse only, adulthood abuse only, and cumulative abuse, childhood and adulthood. And what we found is that individuals who experienced childhood abuse and cumulative abuse were more likely to report co-use of benzos and opioids, which is a really dangerous combination. And cumulative abuse also modified the relationship between anxiety and co-use. So for individuals who experienced cumulative abuse at high levels of anxiety, they were more likely to report co-use. And what was shocking is that at above a score of 15 on the HADS anxiety scale, every single individual within that cumulative abuse group reported co-use. So this might impact how individuals perceive noxious stimuli, both internal and external. It might just be that they are experiencing anxiety more intensely, and it's harder to deal with. They might have a more difficult time coping with this anxiety. And this point is driven home by a previous study by Sturza and Campbell. They interviewed adult rape survivors in an effort to understand prescription medication use after rape. They found that 43% of the women reported sedative or antidepressant use. Of these women, 42% were given medication specifically to cope with the rape after disclosing it to their physician. But 58% did not disclose the assault, and yet they still reported a need for medication in order to handle the rape. So I think the words of this victim are really powerful. I wanted some help to make it stop hurting. I didn't want to tell my doctor, so I don't know, I talked around it, and he gave me something. There's many interventions that exist to help with coping with trauma. And unless we treat the trauma, we're not fully addressing the patient's needs. Right? Cognitive behavioral therapy is perhaps the most well-researched type of intervention to assist with traumatic events. This approach attempts to identify and modify maladaptive thoughts and behaviors. And CBT exists to both help with these emotional, cognitive, and behavioral outcomes of the trauma, but also the health outcomes that we see. And I'm not going to cover these in depth, but I think what's important to note is that there's other therapies out there that are going to help with this mind-body connection. And van der Kolk also stated that individuals who have experienced interpersonal trauma, they don't feel safe in their own bodies. We have to help these individuals feel safe just being who they are. So there's other interventions such as trauma-informed yoga that they have found to be effective for treating trauma and to help individuals really connect with those feelings that they're experiencing and to learn how to cope with that and not feel so unsafe in their own bodies. So I want to thank my amazing mentors and team who are so wonderful. And we're currently collecting data with the PACE project to look at a broad range of traumatic experiences at both the Back and Pain Center and Michigan Medicine broadly, and also social, psychological, and physical functioning, including pain. And that's the Back and Pain Center, where many of the wonderful people that I work with are housed. So yeah, thank you.